Hey everybody, how's it going? If you can hear me, let me know. Get my stuff all set up here. Hey Abby, how's it going? Give a special reward to whoever the first person to write in is. Allison, Cassandra, and Penny, and Brittany. Good to see all of you guys. It's a good afternoon to all of you. Thank you for joining me. Auspicious occasion. Actually, when I logged into some stuff, YouTube was like, oh, a bunch of your passwords have been compromised. So I was like, oh boy, I gotta teach, so perhaps I'll deal with that later. Paige and Kylie and Kelly, everyone else. I know, right? So it looked like it was some sites where I was not too concerned about it. Something you can sign up for like one time, like 10 years ago. Oh my goodness, that's terrible, Matthew. Wow, hopefully you got that all straightened out and got your money back. My gosh. I wonder how they got access to it. And we'll get started here in a few minutes. I actually have a ton of questions up on the sticky board, which is fantastic. I'm glad you guys watched the video and were able to catch back up. Probably a skimmer. Yeah, I'm always worried about skimmers. Like, should I get a wallet with some kind of skimmer protection, or let's check like the gas station card readers, but you never know. Christine? About 30 people in here so far. So we're gonna finish up the ID section today, and then we're gonna move into, what do I have next? ENTs. We'll talk about ENT stuff next. Although I don't know why I didn't put optho second, because that's what you're gonna be. We already had a test on that today, but I guess it doesn't really matter. But oh, how were the interviews? Did any of you act as ambassadors for the interviews? I thought the majority of students that I interviewed were quite good, so it was a good, strong first day. And isn't it nice to not be on that side of the, I would say table, but I guess camera at this point, because you're already in, you're in class, right? It's fantastic. Made it through the gates. They banned you from attending. That's not good. How come? Yeah, it's like you can just go, you can glide in there with like no pressure on you whatsoever and be like, oh yeah, everything's fine or whatever. And then, oh, that's good. I'm glad you weren't really banned. Although if I need to inform anyone, I'll let them know to make you the first one they kick out. Yeah, so the interviews are interesting. We're doing them online, as you might imagine. So we have like a little session in the morning where we're going to introduce everyone, and then the faculty have our own like room set up. So we are not, it's not a breakout room, it's another meeting altogether, and we just have them log in 5 minutes before their thing, and we go through our normal process just like you guys all did. So it's interesting, you know, a lot of accidental talking over people and whatnot, but we get through it. So, all right, so I'm gonna go ahead and I'm gonna start the recording here for our backup. I know, that's what I was saying too, is like the you know, the travel is probably pretty nice on their end, but then on the flip side, they get like a video tour of the campus, but not really like a good feel for, you know, the building, what it's like to be here and all of that. So, you know, there's pluses and minuses, but you know, saving some money is not a bad thing these days. So I had a bunch of questions on the sticky board from the recorded lecture, which I think is fantastic. So again, I encourage you guys to use this as much as possible. Anyway, so some questions you had I can answer. So, should we know chemical structures for each drug? No, do not spend any mental energy remembering that. But if I say something like a beta lactam, you know what that is, right? You can kind of understand what I'm talking about and what that refers to. In terms of the type of drugs that it encompasses and things like that. So yeah, don't know the chemical structure. Sometimes I'll bring it up though, like if it's important in terms of like describing like how a drug works, or if there's like a reason for a particular reaction someone could have to it. I might bring it up here and there, but no, I would not worry too much about the structures there. Someone asked, does daptomycin or cubicin fall under the oxazolinodinone drug class? I try not to say that if I can, because that's a lot. That's the Zyvox drug class. No, daptomycin is kind of a one-off, and it makes sense if you look at the mechanism, with it being quite different than what you saw with Zyvox. So no, I would not call that in the same class. It's just its own one-off kind of drug there. So. Someone said, is Bactrim the same thing as Septra? I noticed you use them interchangeably. Yes. So Bactrim, Septra, they both are different brand names that are going to refer back to sulfamethoxazole and trimethoprim. So I end up using them interchangeably because that's just what everyone calls them. Most people use the brand name because it is harder to say sulfamethoxazole and trimethoprim. It takes a lot longer. So yes. It is important for us to know exactly which organisms an antibiotic can cover, i.e. that tetracyclines cover Yersinia pestis, Brucella, etc. No, I would know the ones that I mentioned as being pretty important. So if I mentioned like, the big ones we talked about were like MRSA, we talked about Pseudomonas, we talked about C. diff. Those are big ones to certainly know if a drug covers them or not. I would also say that have an idea of kind of broadly speaking what they cover. So like know if a set of drugs has good anaerobic coverage, or if it has good atypical coverage, because we're going to get into more of those details like when we get into ENT here in just a little bit. You'll see that too. So someone says, I wasn't sure if you mentioned in lecture if it's crucial for us to know the diseases for each drug. The drug of choice section. Not at this point. When we get into specifics in the individual sections like ENT or Pulm or stuff like that, that'll become more important when we look at first line drugs to choose, second line drugs. That's what we're going to be talking about most frequently. I apologize that the stream dips a little bit in quality there, but anyway, so yeah, we'll get more into those specifics, and you'll see what I'm talking about when we talk about like ophtho and ENT stuff there. So. Let's see. Would we need to know these names below in parentheses, or is it just erythromycin okay? So don't worry about those particular names there. Those are just different salt forms for the drugs that you might find. Sometimes that is important because it can denote how a drug is acting. So in some cases, you may find one's like a long-acting form or one's a short-acting form. So a good example of that would be something like methylprednisolone. So the IV products of methylprednisolone come as either methylprednisolone succinate or methylprednisolone acetate, and they act very differently because the acetate actually sticks around. It's a long-acting steroid versus being just a regular short-acting kind. So sometimes the salt matters, but for our purposes here, like just know erythromycin, and you're going to be pretty good on that standpoint. Let's see. Is it true that if it's time-dependent drug, you look at the trough, and if it's concentration-dependent, you look at the peak level? Yes and no. So in the cases when you're looking at a trough, you're either doing it for two reasons. One of which is if it's a time-dependent antibiotic, you're looking to make sure that the level is staying above the MIC, right? You want to make sure that it doesn't dip too much, because otherwise, you're going to get below the MIC, and the bacteria can then start to propagate again. So in those cases there, you're checking for efficacy because you want to make sure that the drug level is high enough to be efficacious. On the other hand, though, if you're checking a trough level, it is due to the fact that you want to make sure the body is not accumulating the drug and holding on to too much of it. So as an example, when I'm doing, for instance, gentamicin for a patient, say they come in, they have a pneumonia, we want to give them gentamicin for that. Basically what we'll see is that now that we're using the drug's concentration dependent, killing for its benefit, we do like one-time daily dosing of a really big dose as opposed to using smaller doses like Q8 hours, right? So by using that one-time daily dose, that really big dose, we know the concentrations are going to be high because we know the general volume of distribution for the drug, and we know how much the patient weighs and all of that. So we can pretty well estimate what level that patient should achieve, right? And we know it's going to be high enough to get to start to kill off those bacteria. When we're checking troughs on that drug, though, I want to make sure that the levels are very low or undetectable to make sure that they don't accumulate it, because then I have to worry about things like renal toxicity or ototoxicity. And so because of that, that's why we check for troughs on something like a concentration-dependent killer, okay? Now, if I was using gentamicin and I was giving, say, smaller doses every 8 hours, then at those points I may want to check a peak level to make sure that I'm getting high enough to get the kind of kill that I'm looking for. So generally that's how you would use those. So troughs can be either used for efficacy or they can be used to make sure that the body's eliminating it, okay? Because you can have a patient who's on gentamicin and they're on a good dose for a while, but then if their kidney function starts to tank, you'll start to notice those troughs will start to pick up, and then they get to a point where they're accumulating way too much of it, and you have to either stop the dosing or you have to do something to deal with that. Let's see. Someone says, do the macrolides, although macrolides sounds a lot cooler, sounds like a fun extreme sport or something, but they said they're not good for patients who have poor immune system, and then a clinical use for macrolides is the MAC, or Mycoplasma avium complex, which is really only concerned for patients with poor immune system. How is that in that situation it ends up working out? That's a really good question. That sounds pretty counterintuitive to what I just told you, isn't it? You're right. So what I was more broadly speaking about in those cases there is that bacteriostatic antibiotics tend to not be as efficacious in someone who has a really poor immune system, because they really kind of rely on the drugs being able to kind of inhibit reproduction of the bacteria, and then the immune system comes in to help out. In some cases, they're going to find that we don't have a lot of drugs that can cover that particular bacteria, so we kind of go with what we have, right? So in this case here, of someone who is immunocompromised, let's say they have HIV and their CD4 count is quite low, they're at risk for developing that infection. So in some cases, we'll do prophylaxis and actually give them the drug to prevent any MAC from kind of starting to accumulate and colonize. Versus we can use it for actual treatment. Would it be nice if they had a good immune system to help fight that back? Sure, but sometimes you got to do what you got to do. So very good question from that standpoint. So let's see. Can you explain the graphs on slide 33 in lecture 1? Certainly I can. Let me see. Slide 33, all the way back here. Good. Oh yeah, so this is kind of going back to talking about concentration versus time-dependent killing here. So what you're seeing with this left graph here, basically, and I should probably show you the PowerPoint, otherwise I'm going to have you guys yelling at me again. So here's the graph they're talking about. On the left side here, this is basically giving you sort of the nomenclature for what we're talking about. So the peak levels being the highest you get to, troughs being down the lowest level prior to getting another dose, and the MIC can be demarcated here on this line. And so what you can see basically is that the MIC can be sort of demonstrated by having varying concentrations of the drug in a combination with the bacteria itself. So if the level is 0, you can see the bacteria growing no problem. As they start to get higher and higher levels of the drug, you can start to see that it clears out because it's preventing those bacteria from growing. And so at this point I could say, okay, well the MIC, that minimum inhibitory concentration, is 3 micrograms per ml, right? So that's how you end up determining that sort of thing there if you ever hear about an MIC being reported out specifically. So you might hear like MRSA with a MIC to Vanco of like 2 mics per ml or something, just as an example, right? So anyway, what this left side graph here is showing you a time-dependent antibiotic versus a concentration-dependent antibiotic. And remember, all your beta-lactams are going to be time-dependent. Stuff like aminoglycosides and your fluoroquinolones and stuff like that are going to be on the more concentration-dependent side of things. Point being here is that with a time-dependent antibiotic, you're looking for the longest time that you can stay above that MIC as possible. So the wider this is, in this case here, I could get above the MIC again by giving another dose right about this point here to keep that up over the MIC. So the longer this is above the MIC, the better kill you're going to have, okay? For the concentration-dependent killers, the bigger the Cmax is, the better the kill I'm going to have on those bacteria, because you're going to see there that as this starts to dip down, you still have the post-antibiotic effect that's still killing those bacteria, okay? So that's sort of the benefit with that. So if you have more questions, more specific questions, let me know and I can refer back to that. Okay, so I don't see any other questions on the sticky board, so we can get back to talking about our stuff. Oh yes, one other important thing I wanted to mention to you all, so I'm glad most of you are here. Some people were felt a little left out, that they were not able to be an ambassador for the interviews, and I really think that's awesome that you guys really want to participate and be a part of that process, because if you're not there to be a part of the process, then I think the students really lose out on something valuable, because your perspectives, I think, would be, to my mind, much more important to letting someone know, do they want to come to our school or not, versus me talking about it, because I have a vested interest in having students come here. You guys are a little bit more unfiltered and a little, not as biased from that standpoint, right? So it's good that you want to participate. So to that end, we are going to start to rotate ambassadors through. And so what I would recommend you do, and I'll make an announcement for people that might not be viewing right at this moment, is please shoot Sarah an email and let her know that you're interested. And that needs to be by 8 p.m. tonight, okay? Just a quick email saying you're interested, and that way she'll get you the information on how to get trained up and all that stuff. Yeah, so I'm really happy you guys are really interested in that, because, again, you guys sell the program for us, right? You guys are very powerful voices to convince people to come here, because I know how awesome we are, but, it's good to hear it from a fellow student who's, presumably you guys are under all the stress and everything. And if you can still say nice things about the program, then that's fantastic, right? So anyway, getting into the antifungals here. So I'm going to go over these sections briefly, because we're going to talk about these more specifically as we get into places where they become more important. But typically, like, we don't get a lot of fungal infections that we're dealing with. There's a few that are pretty common, but a lot of them are going to be things where, like, they're more prone in, like, patients who are immunocompromised and things like that, because generally the body's pretty good at getting rid of fungi from growing there, right? So in these cases here, we'll talk about some of the more common ones you run into, talk about some of the problems with them, and kind of go from there. But anyway, so very similar to how bacterial cells have different targets that our antibiotics are looking for, we're going to similarly see different targets that our antifungal drugs are going to be looking for. And you can kind of see here how different the cellular structure of the cell wall of the fungus is as compared to bacteria and even human cells here, right? So as you can see here, they have these rigid cell walls that contain chitin, which makes it pretty strong, pretty durable. We're going to see the cell membranes composed of ergosterol, so this will be a really important target here, which I'll mention in just a few moments. They have different ribosomes, different nuclear membrane. It's just very different, and they really don't get a lot of activity in terms of our antibiotics. They just don't work on them, right? Similarly, just like antibiotics don't work on viral infections, antibiotics don't really work on fungal infections, right? So we have to shoot for new targets here. Now, what are some people who are going to be more prone to having a fungal infection? Well, I already mentioned people who have immunodeficiency, whether due to chemotherapy or they have HIV, or maybe they're on immunosuppressants because they have an organ transplant. But anyone who has a predisposition for these infections due to things like indwelling catheters, right? Or maybe they have an endotracheal tube that's been in place for a long time. Burns tend to predispose someone to a fungal infection because they've kind of lost that natural barrier, things like that. Even things like diabetes, where the blood is nice and sweet, fungus likes to chew on that and then propagate. So you can see, like, fungal infections, especially in the feet of diabetic patients, are really poorly controlled. The other big thing too is if you have selective pressure being lost between the bacteria and the fungus, sometimes you can find that the antibiotics can actually predispose someone to a secondary fungal infection, right, which is not great. That and just warm, moist environments, fungus tend to like to grow in. So, like, diaper rash and athlete's foot, things like that, very frequently. So what you're going to find is a lot of the ones that we treat on a day-to-day basis typically involve, like, the skin and mucous membranes. They can become systemic, and when they do, they are really difficult to treat. And frequently, it's, when you think about things like cancer, like, oftentimes it's not necessarily cancer that kills the patient. It could be the fact that we've made them immunocompromised with our chemotherapy, and then they get one of these nasty fungal infections that have gone systemic, and they can't fight it off, and our drugs just aren't good enough to deal with that. So it can be pretty difficult to manage here. So that's why we want to make sure we're doing appropriate care for our patients and preventing them wherever possible in some of those more at-risk populations there. But anyway, so there's a ton of different varieties here. I'm not going to get into all the specifics here. I'm not even really going to cover, in terms of, like, antifungal coverage, which ones cover, Aspergillus versus Candida, etc. I'll mention some of the more common things they're used for, but I'm just kind of showing you some of the more common varieties of fungal infections you might run into, right? So anyway, so here's the list of drugs we're going to cover: the polyenes, flucytosine, the imidazoles, triazoles, echinocandins, griseofulvin, and then the allylamines. And so these are the kind of more common classes here. So I'm going to go over those specifically. So getting into where these work, you can see that generally speaking, things like the polyenes, azoles, and allylamines work more on the cell membrane for the fungus. What you're going to find is a lot of these actually deal with, similar to the beta-lactams, they're disrupting the cell membrane of the fungus. And if you can open up a hole in that cell, in that fungus, then that's going to cause a lot of issues for it and kill it off. So these can be fungicidal drugs here, as you might imagine. You can either do that by actually disrupting the cell membrane integrity directly, or it could do things like inhibiting production of ergosterol, which we saw was an important component of that cell membrane. Some drugs even work on the cell wall specifically, so like the echinocandins, for instance, can help to prevent that cell wall formation. So different actions here for these. You can even do things like inhibiting cell division and mitosis by using something like griseofulvin that actually inhibits the microtubules that are necessary for that occur. If you imagine going through your different phases of mitosis, you remember where the chromosomes all line up in the middle of the cell and they get pulled apart into two new cells. Well, that can't happen if you don't have properly functioning microtubules. There's actually some cancer drugs we're going to see a little later in the class that actually do the same thing. And then we can actually also affect things like nucleic acid synthesis. So sort of similar to how sulfamethoxazole and trimethoprim prevented bacterial cells from using folic acid to produce nucleic acids, we can see the same thing here with flucytosine can actually do that. So again, disrupting and preventing the cell from making new DNA can prevent it from ever replicating in the first place. So first one I want to talk about here is Amphotericin B. A lot of people call this amphoterrible B because it is a pretty nasty drug here. So this is kind of an interesting way that this works. And a lot of times you're going to find that a lot of the drug products that we have, especially kind of the early ones, come from natural sources, right? Because in nature, you'll find that like bacteria and things can produce some of these products because they don't want fungus to crowd it in and prevent it from replicating. Very similar to how we got penicillin from molds. Cephalosporins come from a variety of molds too. You can find some natural sources for these from the animal world, so to speak. So anyway, how this is going to work is this actually forms a channels in the ergosterol membranes in the actual fungal cell membrane, and this allows things like potassium and magnesium to leak out of the cells, right? So you can see here it has a little pore formed in it, and this allows for things just to leak out, which, as you might imagine, can lead to the fungal cell death. Also leads to a lot of oxidative damage in the membranes too. So you can see here how it looks like a big kind of long planar structure. You can imagine that just kind of jamming itself through that ergosterol and opening up a hole there. So you can kind of imagine it kind of working even from a physical standpoint. So it comes in a lot of different formulations here, and so the problem with Amphotericin B is that even though it's causing a big hole to form here in the ergosterol and the fungal cell membrane, the problem though is that you can actually find that it doesn't have perfect selectivity for fungal cells. It actually affects our cells too to some degree, so there's a little more crossover there, and this is why it leads to so many different side effects, which we're going to see in just a moment. Apologize for flipping slides here. Anyway, so this is going to be an IV only product we're going to be giving for mainly systemic fungal infections. So these are for those really sick patients who have poor immune systems and have developed one of these systemic fungal infections. You can get it just plain, and that's all well and good, but it's actually really toxic, and I'll talk about those in a little bit. But it's fairly cheap when it's in the plain sort of variety there. It's been around a while. Instead, though, what we can do to try to limit some of the toxicity is actually using what we call these lipid formulations. And so this is actually a really neat way to organize or to formulate the drugs. So if you can see here, you see the this is actual a phospholipid bilayer that the scientists have produced, the drug manufacturers have produced, and then they actually have little bits of the drug actually impregnated. And I apologize, there's a printer going off. It sounds like my wife has decided to print something in the middle of lecture, which is fun. So, I'm very sorry about that. Anyway, so we have the drug sitting there, and the nice thing here is because it's in this lipid membrane, it actually can prevent the drug from interacting with our cells quite so much and helps to limit the toxicity. The downside, though, is it's actually like super expensive as compared to the non-lipid formulations, like 20 to 50 times more expensive. So anyway, so we can use it for a variety of different types of fungus. Don't worry so much here about the different varieties. I'm sorry, I'm going to try to find a way to cut this off. But that was just real annoying. Anyway, so you can see the different variety of different types of fungus here. Don't memorize that necessarily, but the side effects here are really what helps limit a lot of the treatment that you're going to see. And oftentimes you have to discontinue the drug, even though the patient still has an infection, because of the fact that the drug is causing so many issues there, right? So what are those adverse effects that I'm talking about? Well, one of which is actually you get a lot of like fevers and chills as a result of using this drug, which the patient might have anyway due to their infection. And a lot of this is due to release of things like interleukin-1 and tumor necrosis factor and a lot of other types of inflammatory cytokines that your body can produce. So what do we do about that? Well, we can actually do what we call pre-treatment and actually give these patients medications to try to prevent those reactions from happening. So we can do things like give them acetaminophen, which is an antipyretic. We'll talk about in the ENT section. Things like antihistamines like Benadryl, and then corticosteroids like methylprednisolone or dexamethasone. So all of which we'll talk about it in great detail later on. The other adverse effects we talk about are a lot of these electrolyte abnormalities, which makes sense because just like it allowed for potassium and magnesium to be released out of the fungal cells, it does it to our cells as well. And it can cause the kidneys to release a whole lot of it and leading to things like hypokalemia and hypomagnesemia. You can also see things like hypotension, and it can cause direct renal toxicity as well. And so one of the things we can do to try to prevent that is to really vigorously hydrate the patients by giving them a ton of normal saline along with the drug, and that helps to kind of flush it through and get it eliminated a little bit faster there. So that's one thing you're going to see there. Now, technically in the same category here is going to be another drug called nystatin. And so this is going to be something you're going to see much more often in terms of like things like diaper rash creams and used for topical uses. And then we also use it for things like oral candidiasis, so things like thrush, right? Which you're more likely to see in patients who have immunocompromisation there. This is actually really handy because it's good as a topical preparation there, but it's also not very toxic when taken orally because it actually has like zero bioavailability. So you're like, well, if it doesn't have any bioavailability, why would you take it orally? And this is a case here where if you have thrush in the back of the throat, you can go ahead and have a patient sort of like gargle and swish and swallow or swish and spit, and that will go ahead and allow for the drug to work directly at the site of the infection without worrying about a lot of systemic absorption and toxicity. So nystatin is nice from that standpoint. There's no oral absorption there. Moving on, next we have flucytosine, which is converted into sort of the cytosine deaminase, and basically it's going to be interacting with thymidylate synthase within the fungal cell itself, right? And so oftentimes we're going to use this for really pretty nasty fungal infections, things like cryptococcal meningitis, right? You'll find that any type of meningitis can be very difficult for different types of drugs to penetrate. And so this is where it's going to be pretty serious if you're busting out drugs like this for these type of infections. Again, specific indications I'm probably not going to be asking you on the test to any great degree here, right? Adverse effects with this, so, and again, it's not entirely specific for the fungal cells, right? So what you're going to end up finding is just like it inhibits thymidylate synthase in producing new nucleic acids within the nucleotides within the fungal cells, it can do the same thing to us too. And this means it's going to be affecting a lot of rapidly dividing cells. And you're thinking, well, where do you get the most rapidly dividing cells? Well, just like with like chemotherapy patients, because you're killing off those rapidly dividing cells too, you can expect to see things like the immune system is going to be hit, right? So again, these are probably patients who have bone marrow suppression anyway, for whatever reason. You can suppress that further because you're inhibiting those cells from producing new nucleotides to produce new DNA, right? See some hepatotoxicity. GI disturbances here a lot because you have rapid turnover of your GI cells, so that can be affected too. And this one is only available orally. Again, routes I'm probably not going to ask you real directly unless there's a specific reason to mention it. So for instance, something like nystatin, as I mentioned, is orally used, but not systemically bioavailable. Things like that you'd want to know, but if I just mention it kind of offhand, if it's IV or oral, I wouldn't worry too much about it. Next, we have the imidazoles and triazoles. Now, these ones are pretty interesting in terms of drug interactions because they're going to cause a ton of them and lead to a lot of issues here. So, notice here that in order to form the cell membrane, it actually utilizes CYP450. So, the fungus has its own variety of CYP450 it uses to help form ergosterol. Right? So imagine if you have a drug that came in and actually inhibited the fungal CYP450, it cannot produce that ergosterol. The cell membrane is then unable to continue to have that structural integrity, breaks down, and then kill off the fungus. As you might imagine, there's going to be some crossover here, just like we've seen with Amphotericin B and flucytosine. So anyway, we use this a lot, especially topically. So if you ever see like ketoconazole cream and things like that, or I'll go over the list here in a moment, but we'll use them a lot for like topical sort of fungal infections, so things like athlete's foot and ringworm and things like that. Note here though that when you're applying these drugs topically, there's really not any systemic bioavailability. So if I were to ask you about like some drug interactions, which we'll see here in just a moment, you're going to see that if it's used topically, it's not going to cause any drug interactions because it's not being absorbed systemically, versus if it was given IV or orally or something like that. So ketoconazole is a pretty common one you'll see being used here. Again, mostly topically is where you're going to be seeing this used for like diaper rash and things like that. If you do have it being used systemically, this is where you have to worry about inhibiting CYP3A4, right? Just like inhibits the fungal CYP450, it will inhibit CYP3A4 very significantly, leading to a ton of interactions, right? So you're going to see levels of other drugs rise if they are substrates for CYP3A4. And again, don't worry about the chemical structures here. I'm not so mean as to ask something like that on an exam. Next, we have a newer drug called itraconazole, which is actually available orally. It has pretty good activity, kind of replacing ketoconazole to some degree when used systemically here. And again, it's going to be a substrate for an inhibitor of CYP3A4, so you got to watch out for those drug interactions, right? And if you're not sure, make sure you look this stuff up beforehand. Yeah, Isabel's saying they prescribe ketoconazole topical all the time in derm, for sure. That's like a very fast mover sort of topical prescription for sure. Now note here, this also is teratogenic. And when I say teratogenic, like what does that mean? Well, basically it means that it can cause birth defects in a developing fetus. So this would not be something you'd want to use in a pregnant patient because it can cause either actual birth defects to occur or fetal demise, as the case may be. Okay. Next we have posaconazole, and so this is going to be pretty potent medication here. It's kind of structurally related to itraconazole in terms of like structure, and so it's going to have very similar activity. Here you're going to see some unique side effects though with this one. So for instance, QT prolongation is going to be happening here, so you got to watch out if you're combining this with other drugs that prolong QT. You can see some electrolyte disturbances like hypokalemia, hypomagnesemia, and then rarely you can get some thrombocytopenia along with that. Abby's asking, you said, would you have both brand and generic names on the exam, right? Yes, I will. So I will have brand and generic. Note that on the Pantso, you're only going to have generics. So, keep that in mind for 2 years from now. But yes, for my exams, because I want you to be familiar with being able to look at both, right? You're unlikely to hear a patient talk about, I'm trying to think of a good example here. If they say something like ambisome, it's easier than saying Amphotericin B. Like only us nerdy pharmacists will usually say out the full generic name. Most people try to find an easier way to saying that sort of thing. So you'll say something like Lasix instead of furosemide, for instance. So I'm trying to increase that familiarity for you guys. Now, fluconazole, this is really, really commonly used systemic antifungal drug. This one has really good oral absorption here, and so this is good for patients who maybe nystatin isn't a good option. If you're worried about thrush, you can utilize this for systemic effects. Also good for CNS penetration, so nice for like cryptococcal meningitis and things like that. Again, note here it's going to be a CYP3A4 inhibitor, so it's going to be causing some pretty significant drug interactions as well. This is also another one you're going to see used a lot for like vaginal infections. So if you have fungal vaginal infection, you may see like a fluconazole tablet, vaginal tablet being used potentially. So those are something you'll see there pretty commonly, usually like just a single dose in those cases. Next we have voriconazole. This one is going to be a newer one, as compared to some of the older ones we're talking about here. So even 2002 is relatively recent in the world of antifungal drugs. This one's actually starting to replace amphotericin because it's tolerated much better than you would see with Amphotericin B, especially just the plain variety. So lots of CYP interactions here. Not only does it affect 3A4, but you're going to see even things like 2C19, 2C9. These become really important for certain anticoagulants like warfarin, right? But 3A4 is still kind of the main one you want to be aware of there, right? Anyway, available PO and IV. Actually, it was kind of interesting. The IV formulation, it actually include, in order to get it into solution, it includes something called a cyclodextran, which increases its solubility. And a cyclodextran is basically kind of like a ring-like structure that kind of holds onto and houses the drug, and then it can then be liberated and can go and treat the fungal infection. The reason why I think that's really interesting is because cyclodextran is actually the same way that Febreze works, right? If you take Febreze and like a typical adolescent male, his room smells terrible, just use a ton of Febreze and the cyclodextrins will grab up all the stinky odors. And then, but it's funny though, because it doesn't last forever, because then the room goes back to smelling again, because all the cyclodextrin released all those smelly chemicals, right? So anyway, I thought that's kind of interesting. But if you're using this drug IV, you can actually accumulate that cyclodextrin and lead to some toxicity. So we actually try to convert these patients over to PO as soon as we can in those cases there. Shelby's asking, did you say it inhibits those enzymes listed? Yes. So in this case here, it's going to be inhibiting 2C19, 2C9, and 3A4. Yeah, thank you for pointing that out since I wasn't very clear on my slide there. Now, there's a lot of topical agents which will fit onto this list as well. These are typically things you're going to find like over the counter for treatment of things like, athlete's foot and things like that. So things like clotrimazole, miconazole, teoconazole, those are probably the most common ones you're going to end up seeing being used either vaginally for like, vaginal infections. If you're going to see this being used for like topical purposes here. There's a lot of them, and that's the reason why I just highlighted these three. So these are the ones that you'd be responsible for on the test from this list here. So just FYI on that one. I apologize, my internet's kind of coming in and out a little bit there, but unfortunately, not a whole lot I can do at this moment. All right, next we have another pretty good set of antifungal drugs here called the Echinocandins, and these are pretty easy to determine because they end with fungin on the end here. So you have caspofungin, micafungin, and then anidulafungin. You can see the brand names here. Anyway, so looking at this, you can see they actually work on that cell wall formation. So instead of affecting the cell membrane like your azoles would, these actually end up affecting the cell wall more specifically to cause destruction of the fungal cell. Pretty well tolerated as compared to a lot of other things like ambisome, for instance, or the Amphotericin B. But you can see some side effects like electrolyte disturbances, tachycardia, some insomnia, things like that. So something just to note with that. All right. Trying to make sure the stream's still going okay, but it is what it is. Kind of goes in and out a little bit. Next is going to be Griseofulvin. This is going to be, the highlighted one's OTC. I believe so, yeah. Most of these are going to be OTC. Yeah, definitely. Lotrimin, Monostat, Vagistat. Yeah, those are all going to be OTC drugs there. Yeah. All right, so then looking at these, as I mentioned, Griseofulvin, right? So this is going to be used pretty commonly. I see this used a lot like in urgent care and ERs and whatnot, being prescribed out for topical fungal infections, most commonly things like fingernail infections and toenails. The problem with these are that in order to really treat those nail infections, they take a really long time. So you think about a typical like antibiotic regimen being like 10 days, 14 days, something like that. You have to treat these for like 9 months, 12 months in some cases. So patient compliance goes down pretty significantly over time. And you see that's why there's a lot of recurrence of the infections coming back, because they either think that they're good to go because it looks like it's getting better, and they stop taking it, or they just stop taking for whatever reason and they then come back. So just note with that, anytime the fingernails or toenails are involved, treatment time tend to be pretty long with fungal infections there. So anyway, so these are actually disrupting those mitotic spindles and actually prevent cell division from occurring. And the reason why we use them for a lot of toenail and fingernail infections is they actually get deposited into the keratin cells, where you can see that you're being used for the hair, nails, skin, things like that. So that's why it tends to be pretty effective for those uses there. It's an oral medication, but being used for these topical sorts of purposes, so to speak. Okay. Anyway, so very lipid soluble, pretty good in terms of getting over to the actual site of infection. It just takes a long time for it to work there. And so here you can see in terms of side effects, not a ton, although it does actually induce some enzymes like 2C9. It can actually increase levels of that and can lead to some interactions where it would actually drop levels of drugs being affected there, right? Because you have more enzymes available to metabolize it. Next, we have a couple here, the Allylamines. This includes Naftifine and Terbinafine. These are also going to be over-the-counter agents here, either used topically most commonly or over-the-counter or potentially oral in the case of Terbinafine. Again, these are going to be used for those superficial dermatophyte infections, things like fingernails and toenails again. So just another couple of drugs here in your arsenal that you can use for those type of infections. Then we have Tolnafate, Tough Actin, Tinactin, if anyone is familiar with those old school commercials, although I'm probably dating myself a bit there with my John Madden references. But again, you're going to see this used for a lot of topical dermatophyte infections, things like that. This one is available topical, it's OTC. I'm not going to ask you on the test if something is OTC or not, just FYI. So, could treatment of nails be expedited by removing the nail? That sounds terrible. I think about like torture scenes where they do that. Actually, I don't know. Maybe. I'm not really big on the derm stuff, as it turns out. It's not really one of my passions, so I do not know. If someone came to me with a prescription though to remove their fingernails or toenails, I would probably have to decline that. So, next I have Anthelminthics. So these are actually going to be anti-worm agents here. Again, commonly seen like in a lot of pediatric patients and things like that. This is where we have albendazole and mebendazole are kind of the most common ones you see there. And basically they're able to inhibit microtubules in the actual helminth, the worm itself, and block glucose uptake. No glucose uptake, no energy, parasite dies off. And so you can use it for a variety of different worm types, as you can see here. Again, these are very well tolerated. Most people do very well with this, although there is a small risk for things like Stevens-Johnson syndrome or toxic epidermal necrolysis there, right? And my male matrix, assuming you mean nail matrix cauterized, it was fun. Does not sound like that to me. Yes, it's a no for me. For sure. Here's another one, Pyrantel Pamoy or Pin-X. This is going to be used for like pinworms specifically and some hookworms. Again, this one's actually kind of neat here because it actually affects acetylcholine. So if you recall back to us talking about our autonomic nervous system talk last semester, this actually inhibits cholinesterase, leading to really high levels of acetylcholine, and that actually leads to overactivation at the neuromuscular end plate, which is interesting because by overstimulating that, it actually leads to desensitization and paralysis. This is actually, if you ever heard of the drug called succinylcholine, it's used as a paralytic. It kind of works through a similar mechanism here by overstimulating the neuromuscular end plate to cause fasciculations to occur and then paralysis. So that's why we can do that for patients to intubate them. In this case here, you use Pyrantel in order to paralyze the worm and then it dies off. So kind of a novel mechanism there. But that's it for this section. Let me know if you have any questions as I pull up the next one. Oh, there's a couple of questions here. Let's see. BNT. Let's see. So anyway, so getting into this, so can 5-fluorocytosine be used to slow down the growth of cancer cells because they're fast growing? We use 5-fluorouracil to actually treat cancerous growths and things like that, and treat cancerous cells because yeah, they do have rapid replication, right? So that's why we end up using certain drugs like 5-fluorouracil in order to prevent nucleic acid nucleotide production in order to inhibit mitosis in those cancer cells. So very good. You're getting ahead of me, and we will talk about that in the chemo section probably towards the end of this class here. Let's see. So someone said, sorry if it's been asked before. No problem. You said we don't need to know the dosages, drug of choice, microorganism. What exactly should we focus more on then? So again, know that when I say microorganisms that you should know, like know the big ones we talked about, like MRSA, Pseudomonas, C. diff. Know broadly what the drugs are going to be covering. So like, do they have anaerobic coverage? Do they have good gram-positive coverage, gram-negative coverage, right? So like vancomycin, it's all gram-positive. That's the only thing it's going to treat, and C. diff, right? So it's kind of the broadly speaking thing, and then the specific thing with that. You know, the aminoglycosides, all gram-negative, includes Pseudomonas, right? Those are things you should know. You don't need to know the dosages or the drug of choice until we get to it in that particular section. So when I talk about like acute otitis media, you should know what the go-to drugs are for that when we talk about it. And that's stuff you can be tested on. So that will become more applicable in here in just a few minutes. Someone said, is it important for us to understand the fine details of the MOA of all drugs? Are we learning about, or is it general idea sufficient? For example, for a drug that disrupts cell division, do we just need to know that it disrupts cell division or exactly how it disrupts cell division? I would say go one step deeper than that, right? So it disrupts cell division by disrupting those mitotic spindles, right? Because there's many ways you can affect cell division, right? So flucytosine, for instance, can do it through preventing thymidylate synthase from producing nucleotides. Something like Griseofulvin does it by preventing cell division by inhibiting the microtubules. So go one step deeper than that, right? So for instance, with like penicillins, I know that they work by blocking penicillin binding protein, which inhibits cell wall synthesis, which kills the bacteria, right? That's kind of the level that I'm looking for there, okay? Hope that makes some sense. All right. Next, going to the PowerPoint. Let's look here. We got our ENT section. So the nice thing with that is because we've got all the antibiotics sort of out of the way, we're going to find that it's going to be pretty quick to go over a lot of the drugs we've already talked about, because most of the stuff here is going to be mostly infectious disease, as it turns out, right? So let's talk about our ENT antibiotics, right? Let's talk about otitis media first here. Again, what you're going to find in terms of causative organisms, certainly there's going to be a lot of viral causes for this, and you can have bacterial and viral sort of co-infection happening in, you know, like 2/3 of the cases. Again, I'm not going to ask you percentages on this, so just know that. But the bacteria, I do want you to know sort of the most commonly found bacteria when you're actually finding things like otitis media. And so these are going to be a pretty common set of ENT bugs we're going to find pretty consistently throughout this section here. But we're going to have things like strep pneumoniae, H. influenza, and then Moraxella catarrhalis. Those are the 3 big ones you have to cover. So again, looking at a gram-positive, a gram-negative, and an atypical, right? So what kind of drugs are going to cover that? Well, we're going to talk about it, but you try to have some idea based on what we talked about in previous lectures, right? Now, again, as vaccines come out, and you know, for instance, like H. influenza rates go down because we have a vaccine against that. So things change over time, but these are still sort of the 3 big ones we're going to see. Okay, so the mainstay of therapy here when treating otitis media is going to be high dose amoxicillin. For the majority of patients, they can go and get this. Now, normally we have to give a little bit higher doses because the strep pneumo tends to get resistant to that, especially if you have like a young kid who's getting like multiple courses of antibiotics. They tend to need a little bit higher dosing in order to help overcome that resistance there. If they've been on several courses of antibiotics or been around people who may have resistant bacterial strains of strep pneumo, right? Typically, though, if that's not going to be sufficient to cover it, we can then step up our game a little bit and include a beta-lactamase inhibitor. So this is where we get into things like amoxicillin clavulanic acid augmentin. That's better for like severe or like more resistant disease, or if they've gotten antibiotics within like the previous month. Okay, so this is where I could ask a test question where I could say, okay, a patient comes in and you know you complaining of ear pain, you do your physical exam and you diagnose them with otitis media, right? Which of these drugs would be most appropriate? I'll give you a list of like 4 drugs, right? And so you'd say, okay, well, you know, if there's no issues of previous antibiotic use, if it's the first time occurrence, a high dose of amoxicillin is probably going to be good to go. But what if I include like a bit in the description saying, oh, they just got a round of antibiotics for strep throat in the past month? Then you'd be able to look at that and say like, okay, well, yeah, okay, amoxicillin clavulanic acid, that would be a better choice because they are at risk for having a more resistant set of bacteria could be causing the disease like strep pneumo, okay? If you have someone who's penicillin allergic and they could not receive amoxicillin, this is where you can use something like a 3rd-gen cephalosporin like ceftonir is a really good one to use there, or something like azithromycin. Now, again, you're going to find that resistance to the macrolides has been increasing over time. So this is where stuff like azithromycin may be less effective, as you'll see as time goes on. But either one of these would be pretty well effective for the majority of cases there. Okay. Now, again, when you're talking about things like cultures and things like that, a lot of ENT stuff you don't routinely culture for. There's some exceptions to that, but like otitis media, you don't normally do that unless they have a lot of like really recurrent cases of otitis media, or if like antibiotics just really aren't working there. Typically, treatment durations around 5 to 7 days, but especially in younger kids, more recurrent disease may even go up to 10 days in those cases there. Typically, 5 days is going to be a little less than sufficient in some severe disease, so probably sticking around 7 to 10 days. I'm probably not going to ask you specific on treatment duration times, but that may come up in your medicine courses there. So like Professor Q may ask questions like that. But certainly drug selection is definitely going to be on the table in terms of what the best drug is to use for a patient, which ones they be contraindicated from receiving, things like that. Okay. Now, if a patient starts out on, something like amoxicillin and they had no improvement in 3 days, This is where, and especially if they've not had any antibiotics in the past 3 months, so something that, no predisposition to resistant bugs, this is where we can try to bump up our game and to go, if they were on amoxicillin, bump them up to Augmentin. Or if they were on Augmentin, bump them up to that third generation cephalosporin like Ceftonir. That's probably the most common third gen you're going to use there, especially for outpatient oral use there. In some cases, what we'll do, especially if they can't tolerate oral medications, like they're having some vomiting or something like that, we can actually end up utilizing something like a parenteral. Let's say parenteral, it means like IVIM antibiotic like ceftriaxones. I can actually use an injectable product. We've had some kids who will actually come back to the peds ER for 3 days in a row just to get a Rocephin shot, right? So that's something you can use as an alternative if oral is not going to be a good option. Or if it's so severe, like they're having to be admitted, you're probably going to go with IV anyway, okay? Cassandra's asking, you're talking about the parasitology class. You guys have a nice little side convo. I'm gonna let you guys do your thing there. But anyway, so next, moving on, we have acute bacterial rhinosinusitis. This is going to be the same bacteria as acute otitis media, so strep pneumo, H influenza, and your Moraxella catarrhalis are the most common. Here, though, with rhinosinusitis, you can see some additional organisms potentially, especially if they have some predisposing things like, severe disease or recurrent disease, things like that. You can see things like Staph aureus potentially, some gram-negative bacilli, but these are less common. The problem with a lot of rhinosinusitis is people tend to, they're sick for like 3 to 5 days or something, and then they go in and they want a prescription for an antibiotic, right? And typically it's still viral at that point, or it's unlikely to be bacterial for the majority of patients. So typically you want to look for things like, they have more than 10 days of symptoms. They have worsening symptoms, sort of a resickening that occurs, say, after 5 to 6 days or so. That's going to be better for those cases there where you're thinking, yeah, it's probably more likely bacterial at that point. Now, with rhinosinusitis, because it's a little more difficult to penetrate into the sinuses versus the inner ear or middle ear, what you're going to find is that we're going to have to start off with a little bit higher bit of therapy. So instead of going with like amoxicillin first, we're going to bump it up and go ahead and use Augmentin right off the bat. And the reason why this is because there's a lot of beta-lactamase producing H influenza. So I could use amoxicillin, but they would just tear up the amoxicillin with that beta-lactamase. So by including the clavulanic acid, you can get around that. In some cases, if they could not receive penicillin for whatever reason, this is where you can bust into things like with clindamycin plus cefixime. You'd actually have to use 2 drugs in order to get the same coverage there, or you could use levofloxacin by itself. That could be an option there. But again, we try to hold off on the fluoroquinolones unless we have like a really good reason to use it because of resistance patterns becoming more and more of a problem, like strep pneumo and things like that. Here you can see for like peds treatment, it's going to be a lot longer because again, it's just more difficult to penetrate the sinuses there. Adults maybe 5 to 7 days or so. And honestly, a lot of times though, using things like saline irrigations like a neti pot or something can be quite effective there, even before they get like the antibiotic prescription. So that's something there. Make sure they are using, if you're going to recommend this, make sure they're using safe water. There's been cases of brain parasites like Naegleria that has been acquired through that, and actually warm waters in Florida can actually lead to some Naegleria infections as well. So if you need a reason to stay out of the water, that could be one of them. All right, going into acute pharyngitis, we're going to see here the causative organisms. Most of the time it's going to be viral, but there is one particular bug here you want to be cognizant of, which is going to be this group A beta hemolytic strep, which is about 1/3 of cases. And so this is going to be a case here where you'll have like a kid who will come in and they will go ahead and do like a rapid strep test, and they'll do a culture at the same time. If the rapid strep is positive, then they have strep, and you're going to go ahead and treat them with antibiotics. You'll also send off the culture at the same time, though, because if the rapid strep is negative, you still have to culture it out to see if there really is that group B strep there, or group A strep, I should say. And so if it is, then you would call in a script for the patient because they would need it at that point, because otherwise you would just assume it's viral, right? So Marley was saying, where would you choose the combo 2 drugs over the Levaquin? Like what would indicate that? So in this case here, if you're trying not to use Levaquin due to maybe, for instance, if you work in an area where they have high resistance patterns, so if you look at your antibiogram and you see there's a high degree of resistance for like strep pneumo to Levaquin, that may lead you to not want to choose that. So you can use something like the combo of clindamycin plus cefixime as an alternative there. You're right, generally fewer drugs are better, but in some instances here we have to be a little more judicious in terms of making sure we're saving drugs like levaquin from becoming more resistant over time. So that's the thing too, is levaquin's pretty easy to prescribe and pretty easy to take, and it covers a lot of stuff, which is why it got overused so much in the first place, right? So anyway, so talking about the acute pharyngitis, we do those rapid strep tests because before, anytime someone came in with a sore throat, they get a dose of amoxicillin, and it really wasn't all that great because we were treating a lot of viral infections with that. So for the most part, mainstay of therapy for acute pharyngitis is amoxicillin for 10 days for those kids. And then if they could not take oral, or say you just want to go with like a one-time dose or something, because I don't know if any of you have ever given medicine to kids before, but it is an exercise in frustration, and we have a lot of patience for that because chances are you're probably going to wear a lot of that medication on you. So if you had a patient who's not going to be compliant with the oral therapy, you could use something like that benzathine G penicillin. If you recall, that was that penicillin that came in that sort of that white milky looking sort of fluid, and that's used for IM injection because it's long acting. That base they put it in allows that to be kind of slowly released over time. So there's that. If you had someone who had a true penicillin allergy, remember, in general, cephalosporins are okay for many of those patients there. You may want to give them like a test dose in the urgent care or the ER to see how they respond. If they don't have a reaction, they generally are pretty good to go. But most patients don't have a cross-reactivity. It's like less than 1%. So cephalexin you can use here, clindamycin, azithra, any of those would be perfectly reasonable as alternatives. Cephalexin's pretty straightforward, pretty easy, and it's free at many pharmacies like Publix and Walmart and things like that. So I'd probably go with that one in a lot of cases there. Yeah, the IM injection is real difficult to push. Yeah, that's true. Because again, it's usually you're trying to use a small gauge needle, for patient, to decrease pain, patients getting there. And also because it's in that oily, lipidy kind of base, it's very difficult to push through. So that's a really good point there, Brian. So there are also, if you didn't want to use systemic antibiotics, we could get away with using otic antibiotics, right? So we can actually use some eardrops here. And the benefit of doing something like this is you actually get like really high local concentrations, and you don't really get any systemic side effects from this because there's no real bioavailability out of many of these, okay? So that's the benefit of using something like an otic drop. From a compliance standpoint, it's easier probably to take a tablet, right? But eardrops are, also quite effective for what they do. So we'll use this a lot for like otitis externa and things like that, or it's like swimmers here potentially. So what are we going to do? Well, basically, we can give them in combination typically, along with a glucocorticoid, right? If I say glucocorticoid, corticosteroid, I'm kind of using them interchangeably there. But basically, what does a steroid do for us? Well, it's anti-inflammatory, and I'll talk about that mechanism at a later time. But basically, if you have like a really, just red, aggravated, angry-looking ear that's very inflamed and swollen, using that glucocorticoid really helps out. It doesn't do anything for the bacteria, but it helps to reduce discomfort and pain the patient is feeling there. So that's useful for that purpose. And then the antibiotic can kind of get there, get really high local concentrations, and can kill off those bacteria. So it's unlikely you'll actually see a lot of resistance to these because the concentrations get so high, which is beneficial. So common ones you're going to run into include things like ciprofloxacin. There's the combination of ciprofloxacin plus dexamethasone, which is called Ciprodex. Here's one combination called cortisporin, which is a combination of neomycin, which is actually kind of like an aminoglycoside type drug. There's polymyxin B, which we talked about last time, and then hydrocortisone. Hydrocortisone here being the steroid, dexamethasone being the steroid. And so again, now you're using two different antibiotics plus the steroid there in order to treat that otitis externa, right? And you're like, well, why are you using two antibiotics? You said not to do that typically. In this case here, it's okay because the concentration you're getting are so high that resistance is rarely going to be an issue here, right? So that's a common one you'll see. And then ofloxacin, which is actually going to be one of those first-gen fluoroquinolines that I talked about previously. So any of these, perfectly reasonable. More inflammation's happening there, you're more likely to use something like a corticosteroid. So as I mentioned, otitis media, otitis externa are going to be the most common uses for these. We use this a lot for our kids who are getting ENT surgeries. They're getting like tubes placed or something like that. They'll frequently get a prophylactic round of Ciprodex or something like that in order to help prevent infection from happening. Now that you've opened up that tympanic membrane and have a new avenue for bacteria to sort of get in and cause infection there. Now, there are some caveats here you want to be careful with and know these sort of contraindications, because this will lead you to picking one drug versus another. And so in this case here, neomycin, if a patient's going to have an allergic reaction or hypersensitivity to one of these otic drugs, which is, it's probably not going to be full on anaphylaxis, more likely to be inflammation, redness, itching, things like that. Neomycin is most likely to do that, okay? That's one notable thing. The next one you're going to see with polymyxin B. Now, I mentioned that polymyxin B, when used systemically, is horribly toxic, just like we mentioned in that last lecture. But when used for something like otitis externa, there's not really any bioavailability to it because it can't really get absorbed. There's nowhere for it to go, so it's not really going to cause a lot of issues here. The exception to that is going to be if a patient either has a ruptured TM or if they have tubes in place. That then can allow the polymyxin B to get into the inner ear and cause cochlear damage and hearing loss. And if you recall, when we mentioned polymyxin B previously, we said that ototoxicity was a risk when used systemically. The same risk is here if they have a ruptured TM or some sort of perforation there in the TM where they can get into the inner ear. Okay. Now, Ciprodex is a pretty good drug, but it's like really expensive. So sometimes what we'll do for patients is we can actually use ofloxacin by itself in addition to using ophthalmic dexamethasone, right? So that seems kind of odd because it's like, well, why are you using an ophthalmic drug in the ear? And that's totally okay. You can do that. You can use any kind of eye drop in the ear, and that's perfectly fine. It's not going to cause any issues here. The flip side is not true, right? So we'll talk about that in ophtho, but you cannot use otic products in the eye because it is definitely not formulated for that really sensitive tissue there, right? It's going to cause all kinds of issues in terms of pH and tonicity and all that kind of stuff, right? So next up, here's a couple of ENT antifungal drugs we'll talk about here. So things like ketoconazole, as I mentioned previously. Remember, it's working by preventing that ergosterol formation there. Note that with ketoconazole, you got to worry about things like, the CYP3A4 inhibition. You have to worry about things like QTC prolongation, things like that. And there is some risk for hepatotoxicity. But again, we're trying to use this less and less as a oral product, as a systemic product. But if you're using it topically, generally not going to run into a whole lot of issues there, as I mentioned, because that's really poor bioavailability through the topical route. Next is nystatin, as I talked about. This is used frequently for like prophylaxis for thrush in patients. There are few reasons patients get thrush other than immunocompromisation. There'll be one notable one I'll talk about when we talk about asthma later on. But this is commonly, so if they're either on an inhaled steroid for asthma, if they have immunocompromisation from chemotherapy or HIV or being on immunosuppressants, those are people who are at risk for having oral candidiasis, and this is where we can use nystatin. Remember, this is good because they can swish and spit, swish and swallow. No problems here from a systemic standpoint because it just doesn't get absorbed. So they may have a little stomach upset, but not that I'm really too worried about there. Okay. Let's see. Kaylee's asking, is this because they generally have the same pathogen? Sorry if I missed that. Same pathogens as what? If you can clarify that, I'll answer. Brian's asking, would the dosage for ophthalmic drugs in the ear be significantly more drops or would it be somewhat similar? It's pretty similar. I'd probably say a little bit more. So maybe if you're using like 1 to 2 drops in the eye, you might use like 3 to 4 in the ear. Again, you're getting there's not a whole lot of space in there anyway, and so you can get pretty good coverage with like 3 to 4 drops most commonly. Okay, so there's nystatin. Again, typically used for like oral candidiasis prevention or treatment of thrush, right? Next, I want to talk a little bit about antivirals, which I didn't cover in the bugs and drugs section, but I'll talk about them here. And so basically, how we're going to be working on treating these viral stuff we don't necessarily have good treatment for. So like the cold, like we don't really get antiviral treatment for that necessarily. But for things like herpes virus, things like that, we definitely do have some treatments. We'll talk about those here. Paige is asking, one time a doctor prescribed me eye drops for my ear for swimmer's ear and actually made me lose hearing in my ear. I had to go to an ENT and he told me I almost needed surgery. It was certain drops. Oh, I'm not sure what drops those were. They sound like not very good drops though. I would recommend not using those drops in the ear. Okay, I'm seeing what you're saying. So the same pathogens. No, so I was talking about using the dexamethasone. So like if you had a patient who needed something like Ciprodex and needed an otic antibiotic plus a steroid, and you want to use like one product, because if you can use one combo product, that's generally better for compliance sake. You could do that, but what they don't have any good internet coverage, insurance coverage. That's a Freudian slip because my internet's acting up. If they have poor insurance coverage, they may not pay for it. And if they don't pay for it, they're not going to take it. That's where I can circumvent that and use the two products instead. So I'd use the otic antibiotic of ofloxacin, and then I'd use the ophthalmic dexamethasone, because there's not really like an otic dexamethasone by itself. It's always in combo with ciprofloxacin there. So that's why we ended up doing that. So anyway, so there's a lot of different ways you can affect the virus, very similar to how we can affect bacteria, right? So we can do things like inhibit protein synthesis, we can affect DNA synthesis and things like that. So I'm going to talk about some more common ways we're going to do that. Now, the ones I'm going to mention here most commonly in terms of like ENT issues are going to be things like herpes simplex, right? So you have like cold sores, but certainly this can also cover down into like genital herpes infections and things like that. Chickenpox, shingles, cytomegalovirus. This one you're going to see a lot less commonly, but you'll see that in like immunocompromised patients there for sure. So again, don't worry about the chemical structures. I only mention these here because if you actually look at them, for the most part, if you kind of look, they look very similar to some of our nucleotides, and you're going to see that's actually important for in terms of its mechanism of action, as you'll see here in just a little bit. There's also going to be sort of familial drugs here. So we're actually going to see, for instance, like acyclovir is very structurally related to valacyclovir. And if you notice, it's just like we put a val on there. And look here, we just added something onto the molecule. So what we're going to find is these are actually prodrugs on the right side here. They get turned into, as they go through the liver, into their normal molecules, normal active molecules here. So valacyclovir gets processed in the liver through first pass metabolism, gets converted to acyclovir. Famciclovir turns into pencyclovir, and valganciclovir turns into ganciclovir. That's kind of the relationship between these drugs here. So if you ever see that and wonder why, that's particularly why that is, right? And so these are actually going to be guanine analogs, and they're actually going to be substituting in for the guanine that viruses would normally incorporate into their DNA and RNA, and they will then act as what we call chain terminators, okay? Basically, what this means is that these false nucleotides, the acyclovir and valacyclovir, they prevent the sugar molecules on it that you normally would find in DNA, and so the virus cannot elongate that DNA any further. So it gets attached to the DNA, and then they can't add anything to it, so it terminates any further elongation of the DNA. That's what we call them a chain terminator. I always thought that sounded pretty cool name, but it does not allow the elongation of the DNA. Okay. So as I mentioned, with valacyclovir, acyclovir, these are probably the two most common ones you're going to run into for like routine use for things like herpes virus and whatnot, varicella, things like that. Now the reason why we have valacyclovir is because the bioavailability of acyclovir is pretty poor, like 22%. So by using it as a prodrug, by using valacyclovir or Valtrex, you actually end up getting like 70% bioavailability. So I need less drug in order to get it into the system and to work for whatever viral infection I'm dealing with, right? So that's kind of the benefit of doing that. In terms of adverse effects, it'd be nice if these drugs were really just specific for viruses, but they will affect us as well. And so you can find some degree of bone marrow suppression. This is more likely if you had someone with like some kind of herpes meningitis and you're having to use IV acyclovir. That's where you're going to see more of these really significant side effects. But you can still see some issues when used like for oral outpatient use. But you got to make sure they're going to be maintaining good hydration. The reason why that is because you want to make sure you're keeping the kidneys hydrated, because these drugs have a tendency to crystallize out or come out of solution, and they can actually cause them to crystallize in the renal tubules and cause interstitial renal injury, right? Which can lead to decreased GFR, electrolyte disturbances, fluid disturbances, all kinds of issues there. But make sure they're drinking plenty of water anytime they're taking Valtrex or acyclovir here, okay? Now, again, with a lot of these viral infections, they need to be given as soon as symptom onset occurs, or as close to that as possible, because they can help to shorten the illness, but not if you give it too late, right? And typically, patients will have some degree of like a prodromal sort of phase there, or some phase where the infection is not obvious. That would be the best time to give the drug, but if they don't know that they have the infection, then they're not going to necessarily know to take it, right? So in these cases here, the sooner you can give it, the better. And that's a general caveat with all viral infections for the most part. The sooner you can get it into the patient in terms of symptom onset, the more likely it is to be effective, right? We'll see that with influenza as well in a little bit. Famciclovir and penciclovir work very similar to acyclovir. You're going to find that these are used in cases where patients have a resistant virus to acyclovir. This is kind of the alternative that you can use there. And keep in mind, remember with these prodrugs, it doesn't make sense to ever give these IV because they're prodrugs. They have to go through the liver in the first place. So that you'll only are going to find these prodrugs being used orally, whereas the parent compound, the active form, can be used IV or orally as the case may be. Okay. So again, pretty a little bit higher up on the efficacy side over acyclovir, but also higher up on the toxicity side as well. Okay, and then we have ganciclovir and valganciclovir. I frequently will only see these being used in patients who have really severe immunocompromisation. For instance, if they have like a transplant and they were getting immunosuppressants for that. So, for instance, the one thing that always sticks out in my mind, seeing it on rotations when I was in school all those years ago. We actually had a patient who was in a peds ICU, and she had a type of leukemia. This patient had a bone marrow transplant being done, so she was on a whole bunch of immunosuppressants, and she ended up getting all kinds of fungal infections, viral infections. She ended up having herpes, meningitis. It was really severe. We ended up having to use things like ganciclovir, for instance, in order to help manage that. So anyway, again, similar in terms of coverage, in terms of how they're being used as stuff like acyclovir, but a little bit worse on the side effect profile, right? So things like blood dyscrasias, bone marrow suppression, and you can even see things like, some CNS toxicity like seizures and whatnot. So more toxic, and this is why we end up having to hold off on using these unless we absolutely have to. And even then, some patients have to stop therapy because of all the side effects. Okay. Now, this is topical to, I guess it's not topical because we're not talking about the skin, but it is relevant to talk about oseltamivir or Tamiflu because we're coming up on flu season, and I hope all of you will be getting your flu shot whenever that becomes available. So anyway, so looking at this is going to be useful for treating influenza A and B. This is the main drug that we have, or the one you're going to see most commonly being used for influenza. Flu season is generally between October to March. And this is going to be another prodrug that gets converted over into this carboxylate form, which has some good activity against influenza A and B. What it does, the actual mechanism itself, is it works on inhibiting this neuraminidase, this enzyme here. And so this is actually preventing new virus from actually budding off of the old one, right? So it's preventing sort of that replication of the virus by inhibiting this neuraminidase enzyme here, right? So this is another case here where you want to start treatment as soon as possible. So you want to do it within 48 hours of symptom onset. Otherwise, it's been shown that Tamiflu does nothing in terms of symptomatology, recovery time, anything like that. So you got to start it early. However, there are some instances where you're going to use it anyway, even if it's past 48 hours, because the risk versus benefits really puts you more on the side of just trying it because it might provide some benefit. Who that's going to be in is going to be your more sick patients. So people who have compromised immune systems, like the very young, like less than 2 years of age, especially with severe disease, if they're greater than 65 with severe disease, or if they have any like kind of chronic conditions, immunosuppression. So for instance, like I see this a lot with, maybe you have a kid who got influenza A. It's been like 3 or 4 days, but now they have asthma as well and having a really severe asthma exacerbation. So they're getting admitted for that. Even though they're showing up late and they test positive for flu A and B. Even though they're showing up late, like 4 days after symptom onset, we would still give them the Tamiflu because the downside of giving it is pretty minimal, whereas the upside of managing this kid who is having a severe asthma exacerbation, if it helps, it helps. If not, then whatever. So those cases there, we're more likely to use it even past that 48 hours. Okay. We're certainly seeing resistance over time, which is an issue, but we kind of do what we have to. Hopefully, we'll have some newer drugs out there in the future that can kind of help this drug out. You can see here that it's only available orally, and it does require some renal dose adjustment. So if you have like an older patient with poor kidney function, you want to watch out for that. And the dosing, you can see here, notice here this typically like, weight-based dosing based on these different brackets. I'm not going to ask you this specifically on the test. I'm just kind of illustrating you so you can see how we would dose that and in some of our patients there. So I want to mention, speaking of talking about viruses and stuff, so mentioning let's see, can Tamiflu be taken prophylactically? It's been recently exposed to the flu. I don't see that recommended frequently because of the resistance issues that might cause. So I don't know of anywhere that recommends that specifically for prophylactic use. Not that I'm aware of, right? So the best thing is just to try to wash your hands, try to isolate if you can, but those are the big things. I did want to mention though, so I saw my father the other day, and he actually mentioned that he is taking part in one of the coronavirus vaccine trials, which I thought was really interesting. And he's a retired guy, and he's getting a little bit older, and so I said, "Wow, you're finally now starting to experiment with drugs, huh?" And he goes, "Oh yeah, I'm a human guinea pig here." But anyway, I thought it was interesting because he ended up having 2 different doses, I think about 3-4 weeks apart. And he said that he definitely knows he did not have the placebo, because when he got it, he said it really just kicked his butt. He was having fevers up to like 101, just felt achy, miserable. He's like, there's no way this is placebo. Otherwise, he has a very strong placebo effect happening there. And then he got the second dose a couple weeks later and was totally fine. So I thought that was pretty interesting, and now he is contributing to science. So pretty cool stuff. Anyway, so let's talk a little bit about some ENT anti-inflammatory drugs. So these are going to be like over-the-counter, pretty common stuff you're going to run into, that most patients, they may have already been using themselves, but you can, maybe give them some extra ideas on alternatives to use if they need it, or, how we're going to be using these in the first place. So starting off, I want to talk about aspirin, otherwise known as acetyl salicylic acid. If you ever see that abbreviated ASA, that's what that's referring to, is the actual chemical name itself. And so again, this is going to be available orally. It undergoes renal excretion, so you got to watch out for that and make sure patients have good renal function. Otherwise, they can accumulate this. And you're going to find that in terms of toxicity, aspirin is going to be one of those things that, when I talk about like tox drugs or toxicology and overdoses and things like that, there are a few things that scare me worse than an severe aspirin overdose. So this can be a pretty nasty drug, but is relatively safe when used as appropriate. Anyway, so you're going to see this a lot used, not necessarily for its antipyretic effects. There's going to be some issues with that. You're more often going to be seeing it used for its inhibition of platelet aggregation, right? So patients who've had a previous MI in the past, they could be taking this for cardiac protection, prevent MIs. It improves mortality, so it's good from that standpoint. And the reason why we like it is because actually it's an irreversible inhibitor of those platelets. And it does that by actually blocking this enzyme called COX. Cyclooxygenase is the full name for it. And there's 2 varieties here, COX-1 and COX-2, and I'll talk about what they do here in just a moment. Now, what you're going to find with salicylates, like aspirin, is you're going to find that at these lower doses, like 81 milligrams at 325, that's where you're mainly going to be getting your antiplatelet effect, right? And so you're going to see that, when they say take a baby aspirin a day, that's what they're doing it for. The biggest risk is going to be seen with this is bleeding, which is fairly minimal if you're at these really lower doses. If you're talking about it being used as either as like an analgesic or an antipyretic, this is where you're going to be bumping up to higher doses, and you can start to see more risk for things like GI toxicity associated with this. And I'll talk about why that is in just a moment. Much higher than that, maybe if you had someone like rheumatoid arthritis or something of that nature, and you're using it just purely for its anti-inflammatory actions, this is where you start to run into some other side effects. So some unique things you can see with aspirin are things like tinnitus, right? I know some people say tinnitus, but I used to have a neighbor who was an audiologist, and I asked him what he called it, and he said tinnitus. And so I said, I'm going to listen to him, being that he is the expert. So you can call it whatever you want. Anyway, actually, I had a funny story one time. You guys might not think so, but I was teaching a class, and I said angina, and the class was like, one of the persons in the class was like, don't you mean angina? And I said, well, I mean, I guess you could use either. And she's like, only you and the cardiology person that taught us that stuff says angina. I said, well, wouldn't you listen to the cardiology person that does it for a living? They never a very good response to that. So again, you can say whatever you want, but tinnitus is what I'm going to call it. So the big problems though with salicylates, especially when you get to higher doses, you can run into a lot of like acid-base disturbances, and can be quite fatal if not treated aggressively. But hopefully your patients will never get up into these doses here, right? You can call it ringing in the ears. That's totally fine. What's interesting though is like you think tinnitus, you always think about that ringing in the ears, but frequently it's more like a muffled sound. Like it's almost like you can't hear. Things sound kind of like you got cotton balls in your ear, for instance. And so I'll tell you, one time when I was during my fellowship, I was during my fellowship, my staffing, so to speak, was in the poison center. I was actually on the phones, actually taking calls from people who were, either having accidental exposures or their kids got into something, whatever. And so, and I have a whole bunch of stories I can tell from that. But one of the ones I had was actually this young lady who was suicidal. She'd actually taken a whole bunch of aspirin, and I was trying to get history from her so I can, make sure she gets over to the hospital and all that. But it was interesting because I was trying to ask her questions, and she was like, "Huh? What? Speak up," because she couldn't hear me because of the tinnitus was getting so severe. So I knew that definitely she had a significant aspirin exposure there. But anyway, so these again are what we're going to be seeing typically in terms of like dosage ranges and kind of the common issues you're going to be popping up with. So contraindications, though, you're going to see bleeding disorders. This can worsen that, or if they're on other anticoagulants or antiplatelet drugs, that can increase your bleeding risk. So that's a relative kind of contraindication there. We typically avoid this in pregnancy for the most part. We'll talk more about that in next semester when we get into talking about OB-GYN stuff. But for the most part, you're going to not be using a lot of that, even though you may see it sometimes in cases for preeclampsia, but not often. And then this is actually a really important one here as well, and this is unique for salicylates. Aspirin mainly being the big one, but actually some other salicylates I'll talk about in a moment you may not think about. And so there's a risk, and imagine you have a kid who has chickenpox, has influenza, something like that, and they're feverish, right? They have a fever, so you want to give them an antipyretic. Unfortunately, what can happen here when they've had a viral illness like this and they receive salicylates, they can develop what they call Ray's syndrome. Okay. What is Ray's syndrome? Well, it's this fatty liver encephalopathy, and it typically is going to be for kids less than 16 years of age, so 15 or under, and the mortality, if not caught early, can actually be like close to 50%. It's really, really significant. This happens here, and so they will develop things like vomiting, lethargy, which looks a lot like the viral illness they might have had, and they get this progressive CNS damage along with all this hepatic injury that occurs here as well. So they get this fatty liver, the kidneys take a hit, the CNS takes a hit. It's really, really significant. And again, it looks very similar to upper respiratory tract infections like influenza can. And so it's difficult to tell the difference when they've had this fever here. So what we tell them is, like, if the kid's less than 16, just don't use the aspirin, especially if they had a history of a viral illness recently, or they're having a viral illness now. Does that mean you can never use aspirin in kids? Well, no, we do it occasionally for things like Kawasaki's disease, or we do it for sometimes like cardiac kids who've had like cardiac surgery. Sometimes we'll do it for them for antiplatelet effects, but it's exceedingly rare. So just note that aspirin is not good in kids. And so you can see here, there's a lot more thing out there to try to like tell people about this. And I think for the most people know not to give kids aspirin, but this is just something to look out for. You may notice here I have a Pepto-Bismol on the picture, and you're like, well, why would you have Pepto-Bismol? If you ever look at Pepto-Bismol on the label, it's actually bismuth subsalicylate. So subsalicylate, that's a salicylate, right? So that's why you don't want to use that for kids either. And I'm pretty sure my mom, when I was growing up, was giving me Pepto-Bismol when I had an upset stomach when I was sick as a kid. So luckily, I never got Ray's syndrome, but it could have been a risk, right? So anyway, you can see kind of the different stages here. I'm not going to quiz you on the specific stages, but just know salicylates, Ray's syndrome, know who that can happen in and what to do about it, what to avoid. Just avoid using aspirin in that age group with a history of viral illness, right? Okay, so again, how would you educate patients on this? Well, typically you want to make sure that whenever patients are self-medicating with OTC meds, you want to know them for how long they should be self-treating before they need to start to get concerned and call you up or to go and get further evaluation. Because with patients self-medicating, you can find that they will just medicate forever and not realize that maybe something else is going on, and they're just kind of covering up the symptoms of it. So it's something to note with that. Generally, if the fever is not going away over the course of several days or getting worse, that's when you tell them to go in and get further evaluation, right? Make sure they're not taking NSAIDs with aspirin, because you're going to find these do the same things. I'm going to get more into the mechanism here in just a little bit, so it'll make more sense on why. And anytime they're taking other things that make your risk for bleeding higher, like anticoagulants or drugs that can block platelet activity, don't want to avoid those, use those together unless they've been directed by their cardiologist or whoever is telling them to do that, right? Afraid to leave the house without Pepto or Imodium? Yeah, I'm pretty sure PA school would be a bad place for someone with IBS, for sure. But anyway, so getting into some of the over-the-counter NSAIDs you're going to run into. So when I say NSAID, it's a non-steroidal anti-inflammatory drug, right? So how does it work? Well, they work by inhibiting cyclooxygenase, whereas with aspirin being an irreversible inhibitor, you're going to find that all of the NSAIDs are going to be reversible inhibitors. Aspirin's the only one that's irreversible. So what they do is they inhibit cyclooxygenase. I don't know if I have a picture of it on here. I don't think I do, but I can show you a picture later. Basically, your cell membranes can release a product called arachidonic acid. That arachidonic acid can then be converted over with the use of cyclooxygenase into a whole bunch of inflammatory cytokines, prostaglandins, prostacyclins, thromboxane, all kinds of different products there, right? So those can cause inflammation, right? Either you stub your toe, or if you have a fever, or whatever the case may be, they are through these prostaglandins. And so by inhibiting cyclooxygenase, you prevent that from occurring, from those being made, and thus they decrease the amount of inflammation you're having there, okay? And so that's why it works as an analgesic, as an anti-inflammatory, as an antipyretic, okay? So that's how we're typically going to be using this. So we have ibuprofen, naproxen, or Aleve is another one we'll talk about here in a minute too. Again, I'm not going to ask you about dosing specifically. Now, side effect wise, generally these are going to be pretty well tolerated, but the issue you'll see, especially with patients who are sort of self-medicating with a lot of NSAIDs for pain issues or for whatever the reason is, they are at risk for developing gastrointestinal ulcers, right? They can get perforations, they can get bleeding along with this as well. And well, why would that happen? We'll talk about this more in the GI section of things, but basically what happens is that your stomach produces acid, right? Produces an acid. It's like the pH is like 2 in the stomach, so it can really chew through and destroy a lot of tissue if your stomach was not properly protected, right? And so your stomach is protected by this nice mucus barrier that includes a lot of like bicarbonate and things like that help to protect it from itself, right? That way the stomach acid doesn't start to digest the stomach. So how does that happen? Well, a lot of it is through things like acetylcholine working on muscarinic receptors, but the really important one here is actually it's prostaglandins. Prostaglandins are really important for helping form that gastric protective barrier to prevent the acid from chewing through the stomach. If you're giving NSAIDs chronically, you're going to inhibit one of those cyclooxygenase enzymes. You produce less prostaglandins, you stop producing that barrier. And so as that starts to break down, the HCl that you're producing starts to eat through the stomach, and that can lead to ulcers, perforations, bleeding. Some cases of death have been caused by this. And so when you think about gastric ulcers, there's two big culprits here that you're going to think about. You're thinking about H. pylori, which is a bacterial infection, or you're going to think about NSAIDs. This is where the history is really important to figure out have they been taking NSAIDs chronically or not, as the case may be. So good things to know. Anyway, so you want to know about that. Also, for patients who have like renal dysfunction or CHF, NSAIDs cannot or should not be used regularly for them because there are some issues that pop up with that, and it has a lot to do with the renal physiology, which I will not talk about here so much. I'll probably talk more about when we get into the cardiology section later on. Just know that the NSAIDs tend to cause more fluid retention and edema in patients with CHF and renal dysfunction, either or, okay? So be careful for that. They can cause an acute decrease in renal function due to some of their actions there, which actually I'm just going to draw it out now. Let me see. Let me do something for you guys. Gals. Live adjustments here. Okay, perfect. So you guys can see the paint here. So what I'm going to do is draw out the beginning part of a nephron. I'm going to draw the glomerulus here. Let's see when we get it. So let's say we're dealing with glomerulus. We're going to have here. And again, my art skills are impeccable, so I don't want to hear a single thing from you guys about how bad my art is. Anyway, so here's our glomerulus. So blood flow is coming in this direction. Blood flow is coming out of this direction, and this is where the filtrate happens. This is where the urine is actually being filtered through and being made here, right? So there are things that control how dilated or constricted these arterioles are. And one of the things you're going to find is that when you have NSAIDs on board, and for typical patients that are healthy, this is not going to be an issue. They can compensate for this. But with patients with poor renal function, what you tend to find is that you're going to see that normally prostaglandins cause these to be dilated, right? They're dilated, it means good blood flow coming in, and you get filtration happening here, right? That's all well and good, but what happens if I end up giving someone an NSAID? Well, what happens is you get rid of the prostaglandins, and so instead of having this dilation here, it actually causes it to then constrict. These constrict down, so just like covering the end of a hose or something, or pinching off a hose, you get less blood flow coming in, less filtration happening, and that causes a decrease in the GFR. So this is for patients who don't have a lot of compensation because they have poor renal function. That can cause an acute decrease in their kidney function. Okay, so that's how that works specifically. Okay, if that doesn't make sense, let me know. We're going to talk about that in a lot more detail when we get into cardiology later on, but just I want to give you that brief little bit of info there. Okay, that's also why it leads to a lot of that fluid retention that happens. Okay. Anyway, so what you're going to find is there are a lot of drug interactions that happen here, and it's mostly going to be with cardiac meds, because you're going to find it can affect things like ACE inhibitors and diuretics, mainly through its effects on the kidneys, just like I just showed you on that renal tubule there, or that arteriole going into the glomerulus. That can affect drugs that are renally excreted, things like lithium. I've had a couple of cases of patients coming in with lithium toxicity for their bipolar disorder because they're treating it and then they started taking an NSAID and all of a sudden their levels started to jump up and they had seizures from it, things like methotrexate. We can have some issues here resulting in those toxic levels. So methotrexate being a drug you'll see for like cancer use and rheumatoid conditions and things like that. Another big thing to note here as well is that just like how aspirin has effects to block platelet function, NSAIDs can do the same thing too. So they can lead to more bleeding risk, but the reversibility is the important part there. When aspirin affects a platelet, it affects it for the lifetime of that platelet, meaning, lifetime of platelets like 7 to 10 days. So in order for the body to get platelets that are functioning again in exposure to aspirin, they have to produce new platelets, okay? Because that's irreversible binding of that cyclooxygenase. All of your NSAIDs like Motrin, like naproxen, they are reversible. So as soon as they're processed out of the system, once they're eliminated, then the bleeding risk goes back down, goes back to normal, okay? While they're on an NSAID, bleeding risk goes up. While they're out of the system, bleeding risk goes back down to baseline, okay? So good to note that. Now, in terms of contraindications, again, some of these are going to be relative. So if they're allergic to the product, obviously you don't want to give it to them again. This actually can exacerbate asthma, which is an interesting mechanism, which I'll talk about more in the pulmonology section. But basically, there is a balance between things like prostaglandins, which are formed by cyclooxygenase. And if you disrupt that, you end up producing more of what they call leukotrienes. And leukotrienes are going to be really important for causing bronchoconstriction. So you can have some patients who may be likely to have an asthma exacerbation as a result of forming all these new leukotrienes. This is not everyone. Like I have asthma, for instance, and I'm not bothered by NSAIDs, but some people do have that sensitivity, so you do want to watch out for that. Okay. Typically, we avoid giving NSAIDs in kids less than 6 months of age. This actually has to do with undiagnosed cardiac conditions. Sometimes, if they have what they call patent ductus arteriosus, you can accidentally close that for some patients that they have an undiagnosed heart condition that can actually lead to some big issues there. So typically don't give it to kids less than 6. I'll talk more about that later when we get to talking about pediatric stuff. And then obviously if they have a history of stomach ulcers, renal dysfunction, avoid these as well. Okay. I mean, you can never use an NSAID in someone with a history of peptic ulcer. No, you just have to give it with a bunch of other drugs, and I'll talk about that in the GI section later on. There's some other ones too. There's actually a ton of NSAIDs, so I'm not going to talk about all of them here because those ones are going to be more frequently used for like pain purposes. Here I'm mainly focusing on OTC ones you can see commonly for like antipyretic purposes, So there's Advil or ibuprofen. There's also naproxen, which is Aleve. This one actually has a longer half-life, so you don't have to give it as often. Ibuprofen you're giving like every 6 to 8 hours. In this case here with naproxen, you may only give it once, twice a day. Actually, in a lot of the marketing for Aleve, you'll see that like all day long, all day strong, something like that, as a result of that longer half-life there. So that's why they market it that way. So next off, we have Tylenol, which is acetaminophen. If you ever were curious about where the name Tylenol actually comes from, it actually comes from the chemical name for the drug, so acetyl para-aminophenol. If you look at it here, you see the TYL, and you have the enol at the end there, so Tylenol. That's where the name comes from. You can now wow all of your friends and tell your parents, see, my education's paying off. I know this really esoteric, useless fact now. Perhaps if we can ever go to a restaurant again, maybe a quiz night that'll come up sometime. Anyway, so acetaminophen, is distinctly different in terms of how it works than the NSAIDs. Even though you see them kind of lumped together at the store all the time, they are pretty different. And so whereas the NSAIDs are good as an anti-inflammatory drug, in addition to being an analgesic and antipyretic, Tylenol has no anti-inflammatory properties, okay? It only is going to be an analgesic and antipyretic. We don't really know how it works. We know it probably works somewhere in the brain, but in terms of how it is working, we don't really know. But it's been in use forever. We know a lot about it, just not maybe the full mechanism. As I mentioned, pain, fever, the most common things here. In terms of dosing, you do want to be really cautious to make sure patients are not going to be overdosing themselves inadvertently on Tylenol, and this is why it's really important. There's all kinds of like warning labels on Tylenol bottles because it is so common for patients to get themselves into trouble with Tylenol, right, with acetaminophen. And so basically, we tell them do not go more than 4 grams in 24 hours. And some places even are a little more cautious, and they say don't even go above like say 3250, 3,250 milligrams, right, 3.25 grams. They recommend not going above that because the risk is going to be hepatotoxicity, right? Whereas the NSAIDs had negative effects on the GI tract, stomach specifically, and the kidneys. Here you're going to find the liver is a big thing that takes a hit here. Okay, I'll talk about what it is in just a moment. Benefit though is it's really well tolerated by almost everybody. If you're using therapeutic doses, there's no issues for like patients with hypertension. There's no bleeding risk associated with it at therapeutic doses. So it's really a safe drug as long as you're keeping within the normal dosing guidelines here, right? So no more than 4 grams in 24 hours, which I want you to know. Now, some patients who may be more at risk for developing hepatotoxicity are going to be those that are taking multiple medications that contain Tylenol. So, for instance, if someone was dealing with some pain issue, maybe they broke a leg or something, and they were prescribed hydrocodone and acetaminophen, all they hear is Lortab. They may not know that there's acetaminophen in it, and so they're taking that, and they go home, they take some Tylenol they had in their medicine cabinet. Anyway, you can see how they can double up, and they can get a lot of Tylenol in their system inadvertently. So I got to educate them, let them know don't take any other Tylenol-containing substances outside of this, right? However, you can find some patients who are more prone to that hepatotoxicity tend to be those that are chronic alcohol abusers, patients who have any kind of hepatotoxicity to begin with, like hepatitis. Those are the ones you want to be really cautious with and use even lower doses of the Tylenol for them because they're more at risk for developing hepatotoxicity. The issue of why you get that toxicity is actually due to the fact that you can exhaust some of the metabolic pathways or Tylenol in the liver, and that leads to the byproduct being formed something called NAPQI or NAPQI, NAPQI. That's a really toxic metabolite that the liver can't really handle huge amounts of, and so I can talk about the toxicity and the antidote later on, but basically that's the thing is you exhaust the normal metabolic processes for the liver. That's where you get the issues popping up there. Okay. In terms of contraindications, not a lot. Like unless they have a history of an allergy to it, there's no issues of drug interactions for the most part. No big issues with metabolism interactions. It's just a very safe, well tolerated drug, assuming you're using it in safe doses. Okay. All right. Up next, talk about our antihistamines briefly. So, when you're having an allergic reaction or you're having any kind of hypersensitivity, histamine is going to be released from immune cells, right? And histamine is really important because it leads to that triple response that we see of like redness as a result of vasodilation. They get edema because those dilated vessels cause increased permeability, so they start to get kind of leaky. They leak fluid out into the local area, and they get redness as a result of some of that vasodilation as well, or that flare that happens there, right? So some of the surrounding tissue can be affected as well. So that's a common thing, and you can see this in like mucous membranes. That's why you get like a runny nose when you have allergies acting up, runny, watery eyes, things like that. So what can we do about that? Well, we can use drugs that can block some of these histamine receptors. The main ones I'm going to be talking about for ENT purposes are going to be H1 receptors. H1 and H2. I think there's an H3, but we don't talk about that much. H1 is the main one we're going to talk about for ENT purposes because this is where it's going to be affecting things like the venules. It's going to be affecting things like bronchial smooth muscle. You're going to find it's affecting things like some GI smooth muscle. But the main thing here is H1 for allergies and ENT stuff. H2 receptors we're going to talk about specifically in terms of their activity on the stomach and producing stomach acid. Okay, so we'll talk about that later. Don't worry too much about H2 blockers at this point. So again, when we see H1 receptors being stimulated, we're going to find this increase in post-capillary permeability. We're going to find vasodilation. You're going to have more mucus secretions. You get a nice runny nose. You're going to have that smooth muscle tone is going to be going up there. And you get the itchiness that happens with that due to some nerve endings being stimulated. And then bronchoconstriction can happen too, right? So you can have asthma exacerbations as a result of this activity of histamine, right? So when you're looking at H2 receptors, again, this is the main thing you're going to see is this gastric acid secretion. That's the big one you're going to focus on with that, but we'll talk about those drugs a little bit later on, okay? When we're looking at H1 receptor antagonists, this is what they're going to be doing for us. So we saw what happens when you activate H1 receptors with histamine. Let's see what happens when we block it. You're going to block that vasodilation. You're going to be seeing less edema, less vascular permeability. The itching is going to go down. The hives are going to go down. All it's going to be really, really effective. Okay. However, you're going to find that a lot of your earlier antihistamines, they also have significant CNS effects. They can cross that blood-brain barrier and cause some significant effects, such as sedation, right? Sedation is going to be one of the main side effects you're going to see as a result of using H1 antagonists that are able to get into the CNS, right? This can be synergistic, especially if you're using with other CNS depressants, like alcohol, for instance. This can be a good thing, though, right? Because we can actually use it as an OTC sleep aid. So if you ever see doxylamine, which goes under the brand name Unisom, think sleep, that's what they use it for. So using a side effect for a beneficial purpose there. Some patients will have what we call a paradoxical reaction or paradoxical excitation. And you see this a little more commonly in kids, but basically you'd give a dose of antihistamine to a kid, you think they would get sleepy from it, but they start bouncing off the walls. They get really anxious, they're running around, freaking out. That can happen, and so that's something to note, as happens in a rare number of people, but it's more likely in kids. Overdoses are really kind of interesting with this, with some of its activity, but mainly you're going to see a lot of excitation. You can see seizures that happen there. Is this why Benadryl can cause dementia? Yeah, any kind of CNS depressant like an H1 antagonist, especially an elderly patient, can look very much like dementia, right? So that's why you'll be really cautious whenever you're using sedating medications in elderly patients, because it can really cause them to get kind of loopy, and you don't know, is it worsening dementia or is it the drugs that we gave them? Okay. So a lot of the CNS effects here are mediated through or seen with the first generation drugs. I'll talk about the different generations here in a moment. First generation drugs can get into the brain and can cause those effects. Cassette says, oh no, I have bad allergies. That's okay. You don't have, I don't think you're very old, so I don't think you have to worry too much about that at this point, right? It's not necessarily that it gives you dementia. It just causes the symptoms of dementia in those patients. It could be exacerbated by their pre-existing dementia, right? Anyway, so the second generation drugs, though, they don't cross the CNS, and so they don't have very much sedation. Okay, so that's a big difference between the first and second generation drugs here. Second generation can't cross the CNS, so they don't have any sedation associated with it, or very little sedation. I should say, I don't want to say never, right? The reason why that is actually kind of neat, because from a chemical structural standpoint, they actually add on what they call a tertiary amine. The tertiary amine means there's a nitrogen that has 4 bonds to it, and that gives it a permanent positive charge. And when it has that positive charge, it just bounces off the cell membrane because it can't cross over. It's not very polar anymore, just like we saw when talking about the Henderson-Hasselbalch equation, right? Positive charges lead to less lipophilicity, okay? Kay's asking, I don't understand the comp of Claritin. I don't know say the comp, but does it fall into this category of CNS depressants? That's a really good question. Let's look at Claritin here in just a moment. Just note here too, with with H1 receptor antagonists, specifically the first generation drugs, because they can get into the CNS, they're also going to have more antiemetic activity. Because if you recall, in the brain, the chemoreceptor trigger zone lies there, where a lot of that's mediated. It's also going to have some anti-muscarinic effects. So this is the first place we're starting to see anti-muscarinic activity that can help with drawing out secretions. That's why things like Benadryl frequently are drying. You have like dry mouth and things like that. And they can have some moderate anti-serotonergic effect. This is a minor effect. I wouldn't worry about that too much. But these first two are pretty important in terms of its activity. Okay. As I mentioned, in terms of the antiemetic activity, it's going to be blocking some of the muscarinic receptors on the chemoreceptor trigger zone. And this is why you can have things like promethazine or Phenergan has really strong anti-muscarinic activity, and that can help for things like motion sickness, but it can lead to some side effects, things like or I'm sorry, that's why we use it for a lot of like vertigo and motion sickness, like due to cruise ships and things like that. We use it for its anti-muscarinic properties there, right? As I mentioned, it's going to cause a lot of dry mouth, urinary retention, constipation due to its anti-muscarinic activity as well. So it's going to be another big set of side effects. And what are my problems? I'm going to wrap up here pretty soon. Indications are going to include things like allergic reactions, as I mentioned. So any kind of hypersensitivity, you can use this for. Motion sickness, either due to nausea or vestibular disturbances as a result of that. As I mentioned, OTC sleep remedies. And we can use them as an adjuvant role in anaphylaxis, which means use them as an additional drug with some other ones that we'll use for anaphylaxis. I'll cover that more in detail when we get to the pulmonology section later on. Okay. In terms of side effects, and this is going to be more so with the first generation drugs, is going to be sedation, GI disturbances. Constipation is a really big one, right? Because of the fact that you have anti-muscarinic activity that slows down the GI tract. And then, as I mentioned, dry mouth, urinary retention, blurred vision sometimes, like that. And then occasionally you can see some hypersensitivity, especially with like topical products, but this is pretty rare for the most part. So anyways, I think I'm probably going to leave you on this slide here. Yeah, I'm going to leave you on this slide. But these are the ones I want you to kind of look at in terms of our first generation drugs, our second generation drugs, and we'll talk about this kind of intranasal antihistamine later on. But kind of notice the breakdown between these. So things like chlorpheniramine, dimenhydrinate, which is Dramamine, if you've ever heard of that name, diphenhydramine, hydroxyzine, meclizine, and then promethazine. These are all ones that are able to cross the blood-brain barrier, get in there, have good antiemetic activity. They'll have stronger anticholinergic effects, and they're going to have sedative effects, right? So he's going to knock you out. I remember one time I was like sick. I was like a younger adult, and I was like just feeling really awful, and I was having a lot of vomiting and just felt terrible. My aunt had given me a Phenergan, a promethazine, and I'll tell you what, I felt better, but I think I slept for like 16 hours. I felt like some of these can be like super sedating. It was the greatest sleep of my entire life. I will never achieve a sleep like that again, I don't think. But that's because of its ability to get into the brain, right? So first generation drugs here. Second generation drugs is going to be cetirizine, fexofenadine, and then loratadine. Yeah, Shelby's asking about NyQuil. Does that make you sleep so well? Yeah, because NyQuil contains chlorpheniramines, that first generation antihistamine there. So anyway, second generation drugs, notice here, very low sedative effects, no antiemetic effects, very low anticholinergic effects, because it can't cross over into the CNS because they have that positive charge on it that prevents that from happening, okay? So again, do I care that you know whether chlorpheniramine has medium sedative effects or high? No, but know that the first generation drugs in general can be used for sedatives, can be used as an antiemetic, and will cause anticholinergic side effects. Second generation drugs are not going to do that, okay? That's kind of what I want you to take away from this table here in terms of that, and be able to delineate between your first and second gen drugs, okay? Anyways, I'm going to cut it off there for the day. I got about halfway, a little over halfway through the ENT section. That's pretty good. If you have questions, put them up in the chat. Otherwise, I'm going to look at the thing here. See, Kay was asking, that's why I was asking about Claritin, because it completely knocks me out. So that must be paradoxical effect. That's interesting. Maybe you have some kind of alteration in your blood-brain barrier that allows Claritin to cross over. That's pretty rare that you would see that. That's why I say not no sedation, but very little sedation. So that's very interesting. So maybe you are just an atypical responder to Claritin. I was going to say oddball, but it may have some negative connotations, so I won't say that, right? Okay, so looking at this, someone's asking, is third generation cephalosporin used for AOM because of its coverage for Moraxella catarrhalis, or is there a different reason third gen is used as opposed to another cephalosporin? We mainly use that more for its better gram-positive coverage, so things like resistant strep pneumo is going to cover that. So like a first or second gen is really just not going to cut it in terms of activity there. So, third gens are pretty good at getting your H flu, can get that strep pneumo, so that's mainly what we're using it for from that purpose there. Is a prescription for Tamiflu typically written for 0 refills? Absolutely. Do never write for refills for Tamiflu, right? I'm not sure if I put that on there for your prescription assignments. Maybe I gave away something there. But yeah, because again, why would they need a refill? You give them the full 5-day course. If they have the flu again, they probably need to get retested for that, re-diagnosed, and all of that. So I would never do a refill on Tamiflu. It's not something you'd want them to have kind of as needed refills, because they can't diagnose themselves with flu. You have to do that for them with a rapid flu test, right? Would patients with a past medical history of liver disease be contraindication for acetaminophen use? I would say that would be a relative contraindication, right? So I wouldn't say to never give it to those patients, but I would be very judicious about who I decide to use it in, right? So if it's someone who has, say, issues with coagulation because they're not producing clotting factors due to their hepatitis, is there ammonia up because they can't process it because of their liver dysfunction? Yeah, I'm probably not going to use Tylenol on those patients. If it's someone who has maybe a mildly elevated AST, ALT, maybe I might see if there's an alternative I can use. Can I use an NSAID instead and avoid any risk for hepatotoxicity? If so, then maybe that's a good choice to go with. So unfortunately, it's going to be one of those it depends sort of answers there. That's why it's a relative contraindication, not a absolute contraindication. I remember one time I had a patient who, and again, this is the end of the lecture, so if you want to hop off, you can. But I'm just waiting for more questions. But I had a patient who was trying to, I think he lost his job, and so he was feeling depressed and decided to overdose on Tylenol. And so he took like an entire bottle, one of those big ones you get from Costco. I don't know how he kept it all down, but he went to sleep assuming that he was never going to wake up again. And he woke up the next morning. He really wasn't feeling all that bad. So he's like, "Wow, I guess I must have been meant to live through all this. Maybe that's a sign." And then he went to like a library or something and looked up acetaminophen toxicity and realized that it takes like 24, 36 hours before it really kicks in because your liver can metabolize some of that Tylenol, but it takes time for that to really exhaust all those metabolic pathways. And so then he's like, "Uh-oh, that's not good," because he's running up on the 24-hour mark. So by the time he finally got to the ER, he was so jaundiced from head to toe. I'd never seen that color of yellow in a person before. It was so severe. And so we got the antidote started for him, and he was on it for a really long period of time, probably like a week plus of the antidote. And eventually, the liver is pretty amazing and what it can come back from. And he made a full recovery. He was able to get out and go to a behavioral health center and get some help from him, and never saw him again. But yeah, it's pretty wild what the liver can do in a lot of cases there. All right, what other questions you guys have? Anything at all? Guys and gals, I should say. If nothing else, then you guys are been an awesome audience as usual, and I will see you next time. Have a great rest of your afternoon and evening. Thank you. Nothing else. All right, you guys have a great day. I will end the stream now. See you later.